I'm doing my report on organic personality disorder, which for this video I will be calling OPD. OPD is a mental disorder identified by short or long-term personality disruption caused mainly by trauma to the head or a medical or physical disease rather than a psychiatric illness. OPD affects males and females of all ages in equal numbers. There are several medical conditions that can cause OPD, including serious trauma to the head, a cerebrovascular accident, structural brain damage either caused by tumors or other outside effects to the brain, thyroid or endocrine disorders, or taking drugs that affect the mind. OPD can be short-lived if it's a result of taking medications or drugs. Once the person stops taking those medications or drugs, their condition can improve without any side effect. Another short-term cause could be a tumor. If it's a type of tumor that can be easily removed, the patient, if surgery is an option, the patient can have this tumor removed and then recover from that without any long-lasting effect of the OPD. OPD can be long-lasting or permanent in duration if it is caused by trauma or brain damage. People with OPD exhibit behaviors that they previously were not known to showing. The person's judgment can be so affected that they cannot be left alone. They can get themselves into dangerous situations or may cause harm to themselves or others. They need to be continuously monitored or supervised. Some symptoms of OPD are impaired social judgment, belligerence or an overactive temper, emotional instability, meaning their mood changes just constantly, not like I'm in a bad mood and 2 days later I'm in a good mood, but like minute to minute, up and down like a roller coaster. Inappropriate social behavior, including sexual indiscretion, and sudden behavior changes that goes along with the emotional instability. The symptoms of OPD are usually exhibited in one of three basic patterns, depending on the location and type of injury to the head or the pathology causing the problem. The first and most common pattern causes emotional instability, impaired social judgment, and an overactive temper. This person may not consider the consequences of his actions. The second pattern may include signs of indifference or apathy. This patient has no interest in her environment, like she doesn't care about her job, she doesn't care about her home, she doesn't take care of herself, she's lost interest in her hobbies. And these first two patterns may be caused by damage to the frontal lobe of the brain. The third pattern of damage, which is seen to afflictions of the temporal lobe, shows a tendency to be humorless, redundant in their writing and speech, and these persons seem to show an inclination of being religiously overzealous. They may show extreme rage and paranoia. If the rage or paranoia is the patient's main symptom, their OPD may be labeled as explosive type. The treatment of OPD is usually directed at identifying the cause and treating that. So if it was caused by a person taking medication or drugs, that would be stopped and the person would return to normal. If it's caused by a tumor, if it was surgically appropriate, that would be removed to allow the patient to recover, and then hopefully their condition would go back to normal without a lasting effect of the OPD. If the OPD is a result of some other type of disorder or trauma, you would treat that condition as well as possible. Medications can be helpful, typically psychostimulants, antipsychotics, and dopaminergic is the word. Agents may be useful in managing the symptoms. Drug therapy, if indicated, should be used in combination with education of the patient and the family, in addition to therapy and psychotherapy for the best outcome possible. I'm now going to talk about the blog that I found. It was actually a narrative that was done by a worker who supported a man who they called Juan. That was not his real name, but he supported this man for about 10 months following his care, his treatment, what therapies he was using. Juan was 26 years old and lived in a group home. He was unable to live alone, and his family was not able to care for him. He had previously been diagnosed with intermittent explosive disorder, and his treatment plan was mainly just keeping him so medicated that he was sedated, he was tranquilized, and he really had no quality of life. He exhibited many difficult behaviors such as biting, hitting, injuring himself. He would refuse to take his medications. He would refuse to participate in his day program. He was sedate, but it wasn't affecting his behaviors at all. Like, he was still just as disordered. He was just drugged. This was about the time that the man who wrote my journal that I was reading came into Juan's life. And the first thing they did was analyze his care. They found that the workers that were caring for Juan saw his behavior as vindictive and manipulative, when actually what this worker, his name was Mr. McFerrin, is who wrote my article. He said that Juan simply was out of control. He felt out of control of his life. He felt out of control of his treatment. He felt that none of the treatment was up to him. And so they really opened up a whole new way of treating him. They involved Juan in his psychiatric appointments, asking him how he felt, asking him what he wanted to be responsible for. Basically, all of Juan's life, his family had made his decisions, his medical staff had made his decisions. So the psychiatrist and Mr. McFerrin began to work with Juan together, working on his medication therapy, weaning off some of the medications, changing out medications that really weren't indicated for medications that might work better. And Juan's diagnosis was changed to organic personality syndrome. Once they were really able to get him talking about his treatment, get him off some of the medications, they found that he really didn't have the intermittent explosive disorder, that it was truly an organic personality syndrome. Juan's care staff all began coming to his psychiatric appointments, including his day staff, his residential staff, the program supervisor. Everybody was getting on the same page of how to deal with Juan and his needs. And this really helped Juan know what to expect, know how to be treated, and this was really beneficial. What they found was Juan wanted to have control over his activities, and so they gave him control of his daily activities. And once the control was his, he started making much better choices. He chose to participate in his day program. He chose his self-hygiene, which before it had been lacking. He no longer refused to take his medications. At the time that this was winding down, it's about 15 years old, this journal, but Juan was beginning to work on being in control of self-medicating for an ultimate goal of semi-independent living. It was discovered that the key to managing Juan's care was flexibility. The staff needed to be flexible in dealing with him. The psychiatrist needed to be flexible with his medications. Just because it was indicated didn't mean it was the right one. Some of them had unwanted side effects. And the care staff needed to give up their control, allowing Juan to step in where he was able to control his own life. Juan's daily life, at the end of the journal, his daily life did still require some assistance and support, but with his new regimen of self-care and medication, he was flourishing. He was beginning to set goals for his future, and actually told Mr. McFerrin that he had hope. Thank you.